Thank you. Welcome to my first chair meeting. I'm Assemblywoman Peters and excited to be here for General Government Subcommittee of Ways and Means. Just going to go over a few technical things related to what we're doing at the legislature this year. Due to the COVID-19 pandemic, the legislative building is closed to the public. But you can view this meeting live over the internet on the Nevada Legislature's website by clicking on the View Events tab and selecting this meeting. You can also view the meeting on the legislature's YouTube channel. Persons who wish to provide testimony or attend the meeting virtually must pre-register online, please. Registration opens when an agenda is posted to the Nevada Legislature's website. Upon successful registration, you will receive a telephone number, meeting ID, and instructions for joining the meeting. Registrants are prohibited from sharing that information. Please keep that confidential. And because of time considerations, each caller offering testimony during this period, the period for public comment may be limited to not more than 2 minutes. Let's go ahead and call the meeting to order. And Secretary, would you go ahead and do the roll call, please?
Senator Brooks.
Here.
Senator Dennis.
Here.
Senator Gokachia.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblyman Levitt.
Here.
I'm sorry, I skipped over Assemblywoman Howdigi.
Here.
Assemblywoman Miller.
Here.
And Chair Peters.
Here, thank you so much. There will be public comment period provided at the end of the budget hearings. All right, and we went over where the agenda is and how you can participate. Thank you. Because we are on a digital platform, I would ask that people please state your name clearly before you start talking for our secretaries. They do have to record these minutes, and that just makes life easier for them. And please keep your electronics on mute and yourself on mute if you're not talking, so that we don't get extra noise in the background. Also, folks, committee, if you have questions, please go ahead and use the Zoom chat. I will try and monitor that. If I miss you accidentally, please, feel free to say, hey, if I miss you, and I'll try and catch you then. We will be hearing one budget today from the Public Employees Benefit Program. Is Executive Director Rich available and with us right now?
Yes, I am. Good morning, Chair Peters.
Good morning. Thank you so much for being here. I'm gonna go ahead and let you get started. But I did want to give you a heads up that after your presentation, I'm going to go ahead and jump into comments or questions related to clarification before we get to kind of substantive comments. So why don't you go ahead and start your presentation.
Thank you. Good morning, Chair Peters and members of the committee. My name is Laura Rich. I'm the Executive Officer for the Public Employees Benefits Program. You can hold on 1 second here. I'm going to share my screen so I can bring up the presentation. Okay, you should be able to see that. If not, please let me know. So the Public Employees Benefits Program, who are we? We manage a healthcare program. We have 72,000 members, and that's about 45,000 primary participants and 27,000 dependents. We do offer both our state and non-state employees access to medical, pharmacy, vision, and dental coverage. through a few different plans. So we have a statewide plan that is offered statewide to all participants. It is a PPO plan. We refer to it as the Consumer Driven High Deductible Plan, or CDHP. We are also introducing, which you'll hear about later on in the presentation, a low deductible plan coming this new plan year, which starts in July of 21. And we offer 2 regional plans that, so we have the EPO in the north and an HMO in the south as well. For those members that have access to Medicare, they are Medicare eligible, usually retirees, they have an access through Peb to an individual Medicare marketplace exchange. And then on top of the medical and dental and pharmacy, we also offer supplementary benefits through our voluntary platform. So we offer things such as long-term care, flexible spending accounts, and all kinds of other supplementary insurance products like car insurance and home insurance and things like that. So to give you a little bit of history, the board made several policy decisions, and really the overall goal this year of these policy decisions was to have Peb emulate other similar to commercial health plans, because that is what we are. We are a self-funded health plan, and so we wanted to emulate those the actuarial processes and be much more industry standard. So the board made several policy decisions this year to achieve that goal. We moved to an underwriting of all self-funded plans. Before we would rate our self-funded plans separately and differently through different risk pools. We are now moving to a process where we are underwriting all of our risk pools on all of our self-funded plans. So a Peb participant is a Peb participant. A member, regardless of what plan they're in, is a risk or a liability to the program as far as claims. And so they're all in one bucket. We have also moved to a contribution strategy where all plans, all members receive an equal flat dollar subsidy amount, regardless of what plan they're in. This produces more accurate budget projections. And when you take away the variable of what plan is someone in, it really does help the program make more accurate projections. We also moved to a different Hsa Hra funding structure. Before, we would fund the HSA contributions on the high deductible plan, depending on the employee and also how many dependents they had on their plan. So we would fund a primary employee one way, and then depending on how many dependents they had, we would give them a separate amount of funding for that HSA and HRA. We have moved again to, we're eliminating that dependent variable, one less projection that we have to make to simplify that funding. We've also streamlined all of the tier factors. So again, in the past, Peb would have, we contract actuaries to do an actuarial analysis and rate our plans. They come up with an overall rate of pricing for each of the plans. And then Peb would come in and we would tack on all of our administrative fees and things like that to it. But this was not done in the same actuarial process that the first step was. And so we have now started to include our actuaries through basically from the beginning to the end of that process to make sure that our rates are more actuarially sound, and including all of those admin fees into the overall rate. So budgeted plan design. Back in November, the Governor's Finance Office had requested of all agencies to come up with 12% budget reserve proposals. And so the Peb board met in November and approved various different plan design decisions based on the 12% funding. And moving into December, through the governor's finance office, the governor was successfully able to reinstate some of the funding to Peb. And so ultimately, the plan design that came out of GovRec was a little different from what the board had approved under the 12% proposals earlier in 2020. You'll see that in the GovRec version, the governor was really, the goal here was to preserve a lot of those, the first dollars that a member would have to pay in order to get access to care. And so what are those first dollars? Their deductibles, their premiums, their HSA employer contributions, all of those are initially what can create a barrier if they become too high. And so the governor's recommended budget really focused on keeping those deductibles and the premiums pretty stable, or as stable as possible. So you'll see that compared to that 12% proposal that the board made in November, they are quite a bit lower. He was able to reinstate, the governor's finance office was able to reinstate some of that first dollar coverage. Unfortunately, there were some other eliminations and reductions that had to be made in order to achieve this goal. So the basic life insurance, and you can see down here on the bottom left, you'll see that basic life insurance was reduced. Today we have basic life insurance benefit to all PEB members of $25,000 for actives and $12,500 for retirees. And in the GovRec version, we have reduced this to $15,000 and $7,500 respectively. We also had long-term disability, so I'll go into that a little bit later. You will be hearing a lot of public comment about this. There's some concerns. We do have a 60% benefit today, and that was then eliminated because of the cost that came to the program. And like I said, I will go over this in a few minutes. We also had Medicare HRA contributions. So these are contributions that our retirees receive, those on the Medicare exchange. Today, they're receiving $13 per year of service, and that is now being reduced to $11 per year of service. And it's important to note that this tops out at 20 years. And so, for example, at that $13 per year of service, the most someone gets a month is $260. There were a few other budgeted plan design changes. We had some out-of-network billing charges. The way that Peb performs out-of-network billing charges was changed to 140% of Medicare charges. So we use basically what Medicare would pay, and we will pay 140% of that. Then there's the Smart 90 prescription drug program, as well as the 30-day Express Advantage prescription program. We implemented both of those. This is not going to have a huge member impact. It does narrow the pharmacy network and reduces some of those pharmacies that are available to members. But I believe that the overall impact is very, very significant. I think there's insignificant. It's somewhere around 99% of members will have the pharmacy available to them within 5 miles of their home. Then there was also, like I said, the basic life insurance and the elimination of long-term disability insurance and the Medicare exchange HRA funding levels, which I've already covered. So why did we introduce a new plan this year? First of all, back before COVID hit, and state agencies were initially given budget directions, that initial direction was to introduce flat budgeting. So flat budgeting for Peb, because of medical trend, is essentially a 5% cut. That's our dollar does not go as far last year or this year as it did last year. And so we knew that a flat budget was going to impact the current plan design. It was going to be a significant impact on plan design, and only having a high deductible plan really limits your options as to what kind of impact you're going to have. One of the most likely impacts is we were going to have to raise that deductible, which is, as I said earlier, that is first dollar coverage. Peb, the high deductible plan, does not cover medical services outside of preventive services until you hit that deductible, until you reach that deductible. So raising that deductible is fairly impactful on participants. And so we had to come up with another plan and something that would mitigate the impact of this to members. Also, there was a very strong desire for that low deductible option as well. So we've had public comment and advocates coming to our board meetings for years asking that the low deductible option that we had back in prior to 2011. So it's been at least a decade that we've had this request. And so we've worked towards a low deductible option. And I think we were very successful in introducing a plan that will be very well received by members. So the basics of the new low deductible plan: members do have access to a robust nationwide provider network. This is similar to our high deductible plan where it's offered statewide. It's not a regional plan. So you do have access to your own provider and through a provider network. Referrals are not required. And although we do call this a low deductible plan, there's a lot of copay, so it's very copay based. A lot of these services definitely, they're not going to apply to the deductible. For example, if you go see your primary care specialist or another specialty physician, you do have a copay and not a deductible. These copays do apply to the out-of-pocket max, but they do not apply to the deductible. So the elimination of long-term disability, I wanted to go over this because you will be hearing a lot about it in public comment, and this was a benefit that was eliminated through the governor's recommended budget. So you'll see here that at the 60% level, what that is, and let me go back. So the elimination of long-term disability, what is long-term disability? It's a benefit that pays a percentage of your salary when you become disabled and are unable to work for an extended period of time due to an illness or an injury. At that 60% of your salary level, Peb was paying 9.2. The cost of the program is $9.2 million to offer this benefit, or $6.3 million to offer it at a slightly lower 50% benefit. You can see here I've listed the past claims history for plan year 18, 19, and 20, where obviously in plan year 21, we don't have those final claims yet. But you can see that in plan year 18 and 19, the LTD benefit paid out in benefits about $1.5 million. However, the cost of this benefit to the program was about $9 million. So there is quite a discrepancy there. It is a costly benefit. It's a very important benefit because we do have state employees do not pay into Social Security. And so Social Security disability is not an option for many state employees who do not have a private or previous private sector experience or even recent private sector experience. And so it's a safety net that that we have as state employees. However, there are some alternatives. As I said, SSDI. So if a member, if it's a new employee who has been with the state just a couple years that came from the private sector, they likely have an SSDI or a Social Security benefit that they've paid into. So they would likely have SSDI or may have SSDI. We also have, there's voluntary LTD as well. So there's those folks that wish to purchase long-term disability on their own can do so and purchase a policy on their own. Peb is planning on offering this through our voluntary platform in January of 2022. So this benefit will be available to members. And then there's also PERS retirement disability. So there's any state employee that pays into PERS. And I say this because although state employees do pay into PERS, there's a portion of the NSHE population that does not. So those that do pay into PERS and participate in PERS do have a retirement disability. Again, these are alternatives to long-term disability, but it's not the same benefit. I do want to emphasize that. What are other states doing? Other states are just a quick Google search. Utah and Washington offer similar LTD as Peb does today. It is part of the basic benefit package, and the state actually pays for those premiums. But then we have other states, Colorado, New Mexico, Oregon, Massachusetts. They offer employee paid opt-in options. And so this is a voluntary benefit that is offered to employees. And Colorado and Massachusetts are similar to Nevada, where their employees do not pay into Social Security. So moving on to enrollment projections. Enrollment projections are very, very important in the overall budget of Peb because it's tied to the subsidy amounts, which is where Peb gets the majority of the funding. So you can see here that overall, the enrollment projections are fairly stable. There haven't been a lot of, it's been pretty stable throughout the last biennium. We haven't changed those numbers. It has dropped a little bit due to some the hiring freezes and things like that. So the enrollment projections are a little bit lower moving into the next biennium, but they haven't changed significantly. Then we have inflation assumptions. So inflation assumptions, although Peb does have actuaries who do make specific inflation assumptions specific to Peb, our budget typically includes the GFO, Governor's Finance Office trend. And they have in fiscal year 22 and 23 using, I believe it is economy.com. That is the information that we've received from the Governor's Finance Office. They use the economy.com numbers, which basically show that medical claims we're going to expect to see about 3.5% trend on medical, a 4% trend on pharmacy, 1.75% trend on dental, and then our HMO and EPO premiums, which are not self-funded. Those are, the HMO is actually a fully insured product. That would be a 7% increase on that. What is important to note here about the trend in general is that trend during the off years, if there are any increases, so for example, if medical claims end up being 5% instead of the budgeted 3.5%, that difference must be borne 100% by members in the form of either premium increases or benefit reductions, because there is no mechanism to change this in the off year. So that is one of the challenges that our program faces because of the unknown and having to, especially during COVID, having to really make projections, medical trend projections 2 years out. So this is something that we struggle with internally in the program, just because of the impact and how significant of the, how unknown that is in, moving forward. So employer contributions, the state subsidy levels you see through the last biennium, they have dropped significantly because of the budget reductions. We're going from $783 in FY21 that's the state subsidy level, to 727 in 22 and 755 in 23. You see that it's a little higher in 23. Again, we are focused on that trend in 23 and making sure that any trend we minimize the impact to members in that second year. That's why you see that higher amount in 23 versus 22. Here's a chart here of the state employer contribution subsidy percentage. So that is how much the subsidy is how much the state covers the overall employee, or the overall cost of of coverage. So you can see here that typically we're hovering right around 93 to 95% year to year of the entire cost of healthcare coverage for that employee only. For state active employees, it is reduced slightly for the retirees. We were going from about 64, it went up in 19 and 20 to 65 and 66. It's going back down to the 62% moving forward. So reserves history. We'll go into reserves a little bit here, but the program has 3 reserve categories. We have an HRA reserve, an IBNR, which is incurred but not reported. And then we have catastrophic reserves and differential cash, which you've probably recognized as excess reserves. And so the first 3, the HRA, IBNR, and catastrophic, are required reserve levels. Those are based on an actuarial methodology based on the claims amount. So those are required and will fluctuate based on what our claims liability is projected to be. The differential cash or excess reserves is the difference basically between the revenue coming in and the expenditures going out. And so you can see that has dropped significantly within the last couple of years. We've been trying to spend down after many years of accruing those excess reserves. We have been making an attempt to spend those down, and projections are that we are hitting the mark here in 2022 and 2023. We don't expect to have a significant amount of reserves. Again, that is all dependent on what COVID looks like moving forward as well. These are just the numbers that you saw in that last chart. So what are our revenue sources, our funding sources? So we have the state subsidy level, state subsidies, which are about 55%, which is most of what our funding is. And then we have the employee contributions. Obviously, that's the 14%. And then we have other sources. We also have what are our expenditures? In $1 billion budget, most of our expenditures are claims. You see that 55% of the expenditures are for our self-funded claims, and then 9% are for the fully insured product. We do have a very, very small operating budget and an admin cost. So our recommended, the governor's recommended budget includes some maintenance units, which are basically their basic decision units where, we didn't include anything outside of the standard here. Enhancement units, it's the same thing. We have just the required, we've got some equipment replacement and things like that. Performance measures, again, those did not change much moving forward. They're very similar to what you've seen in the past. I talked about some variables. I think this is very important to touch on. So there are variables, a lot of variables that are likely to impact the PEB budget. First of all, we have many contracts that are due to expire that that we've already been going out to bid for, and we've already awarded. Actually, yesterday at BOE, we had, I believe, several contracts on there that got approved. So in FY22, we did approve we will have a new network. The network is essentially what is going to determine the cost of claims. And so moving to a new network, although we are projecting savings on the new network, it's something that will definitely impact the PEB budget. We also have a new dental network, and actually we are retaining the same vendor on that one, and also on the HMO plan, the Health Maintenance Organization. We're also changing financial auditors. That is out for bid right now. We have a new health plan auditor, and we are implementing a new benefits management system. So all of these have an impact to the PEB budget. Moving into 23, we've got very major contracts that may be switching hands as well. So we have the third-party administrator. This is essentially the one of the most impactful changes should it change vendors, not only to PEB but to the membership as well. We have a national medical network that will be going out to bid as well. And then we have the PBM, the pharmacy benefits manager. Anyone who has a prescription deals with the PBM. And so this is this will impact members, and also, again, our PEB budget. Pharmacy is a big part of our claims cost. We also have the basic life insurance going out to bid, and the actuarial consulting services. Claims are going to be a huge variable. As you've heard me say, that COVID-19 is going to drive this. In the past, we have been receiving coronavirus reimbursement funds for any of the COVID-19 claims cost. But moving forward, that is something that, we may not be able to depend on. And so these medical costs, these COVID-19 medical costs that are trickling in, especially, I know yesterday I received the updated COVID claims. I get one every week. And just in the last 2 weeks, we have seen a $1 million spike in COVID-19 claims costs. This is due to the claims that are trickling in from the hospitalization and treatment from December and January. So if you recall, there was a very significant spike in COVID-19 during that time, and we are now just beginning to see those claims costs come in. So this will definitely impact the program moving forward, because again, we are typically, when we project medical trend, there's expectations, there's modeling, there is, we can look at experience, but coronavirus is one of these things that we don't have experience on. This is a relatively unknown variable that can definitely impact things, especially moving into FY23. So, for example, we have many members who have not received the surgeries and care that they would have normally received, and they've been putting off care because of the pandemic. So what is that going to look like in FY23? What if the healthcare costs are, or the health conditions are worsened because of the delay in getting care in 21 and 22? So these are all things that can impact the program. Additionally, plan design changes. We have a new plan. We don't know how people are going to utilize it the first few years. Usually you've got the first year or two, you've got some people that don't use it at the right levels, or maybe they use it more. So there's the introduction of a new plan introduces some element of a variable that you don't know. And then, as I said, medical and pharmacy trend. One thing I didn't cover was vaccine costs. So while the vaccine comes at no cost, just like when we administer a flu vaccine, those come with a administrative cost. So usually the provider will charge an administrative fee that's associated with that. So I've been seeing those vaccine costs trickle in, and they're looking at about $20 to $25, $30 or so per vaccine. So you can, $30 at, let's say every member gets vaccinated, then you're looking at a significant cost to the program as well. Something that is very important to discuss at this committee meeting in particular is our Peb timeline. So typically in November, plan design is approved. And why do we do it in November? It's because there is a lot of work that goes into all of these, into getting ready for open enrollment, which is in May. So in November, the board meets and plan design is approved. So starting in December, we begin to really, all the work starts taking place. So operational and IT needs to implement the approved program plan design are assessed. So for example, we have a new plan. We have to build this into the eligibility system, and there's testing and things like that are involved. And so all of this starts taking place in December. We begin to coordinate with vendors. We begin to start updating and developing new plan documents. All of the open enrollment material, there's a lot of open enrollment material that has to be updated, and benefit guides, member communication, things like that. We start planning open enrollment meetings and webinars, things like that all start to take place. In January, our board meets again, and any remaining plan design decisions are approved. Once that is done, then January through March, we have staff internally who are working very, very hard. They're updating the plan documents and websites and things like that, ready for open enrollment, making sure that all our ducks are in a row for the open enrollment in May. In March, the board meets and rates are approved. Why do we wait until March? It's because we need to have that most up-to-date experience. And when I say experience, it's what is the utilization in the plan? So the actuaries cannot price the plans without having that most up-to-date utilization. And so we really wait until really the last possible minute to establish those rates. So in March, the board approves rates, and right after that March board meetings, we start loading the rates into the eligibility, the enrollment and eligibility system. And those rates are all tested. They're included in all of the plan documents and member communications. And I'll tell you what, we have members calling well before March to find out what these rates are. And so the delay of rates, as we've had in the last few years, have really, really impacted members in a negative manner, because it's really the way that they determine what plan that they want to be on moving forward in that new plan year. And so in the month of April, we are testing those rates. We are putting on open enrollment meetings. We are holding webinars. We're doing everything that we need to do, updating the website to reflect all of the new plan year enrollment materials. And then on May 1st, that is the first day of open enrollment. Members have a month to make those changes through open enrollment. And then they have up until June 15th to support or to submit any supporting documents. So birth certificates, marriage certificates, things like that, if they add any members to their coverage. And then on July 1st, the new plan year begins. And so the reason that this timeline is posted is because I know in previous sessions, we've had some issues with our, with delays in our budget and the subsidy levels and things like that. And so it's important for the members of this committee to understand the timeline and know concurrently what track Peb is on versus what track that the legislative track is on as well, to make sure that we can reduce any member impact as much as possible through this legislative session. So with that concludes my presentation, and I will be happy to take any questions from the members.
Thank you, Ms. Rich. There's a lot of information, and I know you've given us this presentation, most of it, twice now. I'm still working to wrap my head around how some of this works, and have been known to staff to ask the same question multiple times. But I wanted to get started, since there are quite a few new members on this committee, with some clarifying questions on just how the program functions. And the first one I want to ask has to do with the Peb board process. How does that work and feed into what we receive as the plan designs?
So for the record, Laura Rich. Typically, the board will approve the Peb budget. So in a normal year, the executive officer would present a series of a report to the board, and then agency request budget would be built based off of those decisions and submitted. Now, once an agency, and this is not applies to most other agencies in the state, once an agency submits their agency request budget, it then is in the hands of the governor, of the governor's finance office. And so in the past, there have been changes that have been made to Peb's budget, as well as, I'm assuming, other agencies as well. This is what the governor's finance office does. It is their responsibility. They are authorized to make changes based on what is necessary and what the governor wants to include in his recommended budget. Unfortunately, this year, with the unfortunate circumstances, the fiscal circumstances that we were facing, we were pressed for time. And so when the board met in November, the Peb board was tasked with making those 12% proposed plan design changes. And so based on that, we submitted the budget to the governor's finance office. As you know, between the end of November to the end of December, there was a lot of new information that came out, especially through the economic forum. And so the governor's finance office was able to then reinstate some of the funding to Peb. At that point, the fund, so with Peb specifically, our budget is so closely tied to plan design that when you make budget changes, it makes plan design changes. That is, there's only certain levers that we can use, and most of them are tied to plan design. And so The governor's finance office worked with Peb to make proposed changes based on the funding that was available at the time and that direction that was given to Peb. So it did not come back to the Peb board, but it was well within the authority of GFO to make those changes and to for the governor to include the recommendations in his recommended budget. So hopefully that makes sense.
That helps to paint a picture of how much work has gone into this already. My other question related to the PEB board is the public input process. So how much input does the public have in the development of these plan designs?
So for the record, Laura Rich, so there's two aspects of this. We do have obviously a lot of public comment, and we have advocacy groups that show up to all of the board meetings, and they are offered opportunities to speak at public comment. Additionally, I will add that I invite the advocacy groups before every board meeting, and occasionally outside of those time frames as well, to have meetings with them and have discussions about the proposed solutions or recommendations that are being made to the board. So the public is very actively involved from my perspective. Board members are very receptive to public comment, and we have definitely heard, as you saw in my presentation, the reason for the new low deductible plan is because we've had them come to public comment and ask for this over and over. And so we made sure that this was something that we focused on to ensure that, we were able to meet the needs of our members.
So just rounding that out, with the Gov's recommendation to eliminate the long-term disability, was there a public input process through PEB for that decision?
For the record, Laura Rich, so in November, there was a series of options that the board was able to choose from. And there was a lot of discussion over all of these options. There was a lot of public input. I believe the November board meeting was over 8 hours long. And I think the public comment was at least an hour, if not more, maybe even an hour and a half of the meeting initially. So there was definitely a lot of public comment around that, and there was a lot of discussion around the elimination of long-term disability as well.
Okay, thank you for clearing that up. I'm going to ask Assemblyman Levitt for his question first.
Thank you, Madam Chair. And thank you, Director Rich, for your presentation. I just had a question, and you kind of glossed over the slide that had my question in it. And maybe it's just my own ignorance, but as I was looking at between 20 and 21, the balance forward was substantial. And if these numbers are right, it was almost 4,000% change from 20 to 21, and maybe there's a reason for that. I just don't. It just, when something jumps that fast and that much, I just have to ask the question as to what that's about.
Sure, and actually, I have our Miss Carrie Eaton, our Chief Financial Officer, in the room here as well. So I'm going to have her come and address the question if possible. Hello, Carrie Eaton for the record. I'm assuming, are you looking at slide, I believe, 13 for the carry forward amounts?
It was 13 or 14.
Okay, so those carry forward amounts are made up of all of the three required reserve categories, in addition to whatever is left in excess. So for 22, I believe, we have more required reserves than in 23, I believe, because we had more excess.
Well, in 2020, the actual was negative balance of 4,264,000. And then in 21, it jumps to 154.5 million. And so that just seems like a huge jump, unless the numbers are just, I just received like a bad copy or something, but.
Assemblyman Levitt, I'm going to ask staff if they may be able to clarify on your question.
Thank you, Chair Peters. This is Alex Hartz for the record. Assemblyman Levitt, members of the subcommittee, I believe you are referring to a table at the top of your notes of your highlight document. If that is correct, you are correct that it shows a 3,724% change between FY20 actual and FY21. There is a note at the right underneath the table that's entitled note number 1 that explains that that is a mathematical artifact of how our system, the budgeting system, treats a balance forward between years. And so, as it explains in the note, the difference is only about 4,000. It's only about a 4,260. I'm sorry, 4 million difference between the two balance boards that actually occurred.
Thank you for explaining that, because the note was a little confusing as well, and that's why I asked the question. So when we receive this cycle, will the actual on 21 accordingly be in a negative, in according to this particular? Will it after all of the mathematical anomalies are cured because we have actual numbers and it's actually came to fruition?
The answer to that is possibly. It depends on the amount that is at the end of fiscal year 21, the amount that is balanced forward into fiscal year 22.
Thank you. Thank you for that. Thank you, Madam Chair.
Thank you, Madam Chair.
Thank you for the question and answer. All right, I think I'm going to go ahead. I guess I still have a couple of clarifying questions to get on the record related to the long-term disability program and the cuts to the HRA Medicare. This is kind of a question or a comment more than a question, I suppose, but the cost savings for the state compared to the loss of income for these folks receiving this benefit, this is a $30 reduction a month for a 15-year of service recipient, and I'm sorry, I'm talking about the Medicare retiree HRA program. Having lived on a fixed income as a single person in college, I know that $30 can mean quite a lot, let alone if you're dealing with disability issues or heavy medical costs. So I wanted to ask how you guys assessed that change and what weights you used for that change.
So for the record, Laura Rich. So first of all, let me explain the HRA contribution. The HRA contribution is it is meant to assist with the cost of the Medicare retirees out-of-pocket expenses. So these are our premiums and out-of-pocket expenses. I believe 94% of those who use an HRA use it to cover their Medicare plan premiums, to be reimbursed for their Medicare plan premiums. The out-of-pocket expenses that the members incur are typically very low on Medicare plans. And so, they may have a $7 out-of-pocket copay or something like that, but they're typically very low compared to what those members on let's say a CDHP or a low deductible plan would typically incur, the pre-Medicare or active employees. And I'm sorry, Chair Peters, can you repeat your question regarding the other part of your question? I can't recall what it is now. I'm sorry.
No, my main question was just how do you use the balance, or how do you assess the reduction, balancing the impact to recipients, or if that is really outside of the way you guys assess changes to these programs?
So the reason that, for the record, Laura Rich, for the reason that this decision was made, I believe it was the thought behind this was reductions are going to have to be made, and they affect every group. And so we have active employees, we have retirees, we have singles, we have families, we have states and non-states. So there's different types of groups that are on the plan. And so when we were looking at how do we find places to reduce, the goal was to essentially spread the pain and not just have one group take on the entire burden of these reductions. And so this was more of a this is how the retirees, so Medicare exchange retirees, we do not, PEB is not liable for their claims because they are Medicare eligible. They're on these Medicare plans, so we're not paying their claims. However, we do provide them this HRA contribution depending on years of service. And so this was just one of many options that PEB had to make reductions, and one way to kind of spread the pain among all groups, if that makes sense.
Yeah, I can understand that. You gave us the numbers for how many folks are on long-term disability through your program, but how many folks are on your HRA, your Medicare HRA program?
For the record, Laura Rich, we have approximately, it's in the 12,000 range, about 12,000 members.
All right, thank you. I'm going to go ahead and move on to Vice Chair Howdigi. You have a question?
Thank you, Chair. And I have a couple of questions, if that's okay. Well, series. Okay, I just want to start with my first one. It's just a clarifying, just to make sure I wrote my notes down correctly, Ms. Rich. Now, did you say that preventative care is not currently covered in the high deductible plan, but it's covered in the new low deductible plan?
So preventive care is, for the record, Laura Rich, preventive care is covered under all plans. This is part of the ACA. And what I think what I meant to say was that on the high deductible plan, outside of preventive care, which does come at no cost, in order to receive care, you're subject to a deductible. So any time that you would receive care outside of those preventive services, a member would have to pay upfront up through that deductible.
And they would not have to pay on the low deductible plan?
For the record, Laura Rich, it works similar with the low deductible plan. It's just much lower. So instead of the $1,750, they're only subject to $500, which is, much different. It's a much lower dollar amount to come up with in order to receive care.
And then, Madam Chair, if I could ask a couple more questions regarding long-term disability.
Please go ahead.
Okay, thank you. And then I had a similar question to what Chair Peters had in regards to the HRA, but kind of, can you walk me through what weights you guys used in your, I think it was November meeting to get to the 50% benefit level as a 12% budget reduction? What considerations did you guys have?
So for the record, Laura Rich, as I said, there were various options that were presented to the board at the November board meeting. And so the board had to come up with had to choose many of those options in order to come up with the 12%, which at the time, that's $72 million for Peb for the biennium. And so it's quite a large number to come up with. And so the board discussed all of the options that were available and decided what options were the most palatable. I don't think any option was a good option, but it was the best of the best of all the bad ones. And the board did look at long-term disability, and at the time, I believe what was presented was the elimination of long-term disability. However, there was a concern to completely eliminate it. And so the option that was approved at the November board meeting was to reduce it to a 50% benefit level versus a 60% benefit level. And so the savings obviously were not as dramatic as fully eliminating it, but so the board had to make other changes, and the other decisions that were made were, I believe, they were to, in order to offset that amount, it was to carve out dental. And so a dental program that right now dental is embedded into the medical premium. The decision in November was to carve it out and make it opt-in. And those that chose to opt in, it would increase the premium by $5, $10, or $15, depending on which tier. And so that definitely made a difference to the overall premiums that were offered onto the program, or for overall rates for members.
And just in staying in the long-term disability lane, if the coverage is eliminated, did you guys look at what it would look like if participants tried to purchase it on their own or voluntarily signed up for it, and what that cost would be to participants?
For the record, Laura Rich, yes, it's typically, it is about 1 to 3% of your income. And so it's different for everybody because of the benefits of Peb pays it on a group level. And we pay the premiums on a group level. If you were to purchase it individually, it would be similar to, for example, car insurance, right? It's very specific to an individual's position. Long-term disability is similar. So it would be age, and what is the other factors would be what is your income. So it's a lot different for someone with an income of $40,000 versus someone with an income of $120,000. And so it's very individual as far as what the costs would be if members are to purchase it on their own. It's definitely, it's a significant cost because it is 1 to 3% of your salary typically.
And then I know, Madam Chair, may I have a follow-up? Okay, thank you. Now I know that we're looking at your budgets for 22 and 23, but as you were going over the Peb timeline, you mentioned that you guys start planning in December. So if funds become available, you guys start planning in December of 21 for the 22 plan year, if funds become available, would you be able to restore any of these benefits before the next legislative session? Is that possible?
Laura Rich, for the record, anything is possible. Some things are just a lot easier than others. So for example, restoring long-term disability it doesn't play into plan design. And so we don't need actuaries to get involved. We don't need, there's not a, it's fairly simple. We know the cost to that, and that could easily be restored. Whereas things like if you want to take away from plan design and restore that funding used for maybe restore long-term disability, then that becomes a lot more complex, because as I said, there's a lot of work that goes into putting the master plan documents together, open enrollment materials and things like that. And so it's doable. It's definitely, we would be scrambling. Additionally, when the actuaries present modeling for the March rate setting meeting, in order to do that accurately, they need to understand what plan design will be. And so if there are any changes to plan design, that is where we get into the more complex situations. But restoring long-term disability or HRA funding or life insurance makes much less of an impact.
Okay, perfect. And then again, okay, yeah, because that's what I was looking for. So like, and I think I misspoke. I said plan year 22, but in December of 2021, you guys would be planning for plan year 23. So if some of these benefits were eliminated in December 21, and there was funds available in December 21, we could start having the discussions around, HRA, long-term disability, and life insurance for the 23 plan year, restoring those. Yeah.
For the record, Laura Rich, yes, that would be much easier than for going into plan year 22. Yes.
Yeah. And I meant plan year 23. I just thank you. And then thank you, Madam Chair.
Thank you, Assemblywoman and Vice Chair. Okay, the next question that I have, I think, is coming from Senator Dennis.
Yes. So I want to ask about the long-term. Let me find my place. Sorry. When we talk about contribution percentages, in the past they were set at specific, and you had a chart that was on this. Oh, I guess I need to unmute. Does that work? Okay. You had percentages in the past that were set, and you had a chart that was on this. It showed at 95% and 83% for state actives versus dependent, and then the dependents were usually 20% less than that of the participants. Can you explain the rationale how those contribution percentages for participants and dependents were set for the 21-23 biennium? I think you kind of alluded to it, but I wanted a little bit more detail.
For the record, Laura Rich, we actually in board policy have the board has an equation, a mathematical equation that is used to determine the dependent rates. And this is what our actuaries use to produce those rates. I believe in plan year 20, our current plan year in 21. So last March, the board strayed somewhat from that. And so that changed a little bit. This is actually something that we are going to be discussing at the March board meeting when we set rates. The board is going to be reassessing that formula that is used to determine the dependent subsidies.
How did the formula, how was it created in the first place?
For the record, Laura Rich, I'd have to go back and look at the history, but I believe it's in our board policies and procedures. And I believe it was determined with the assistance of the actuarial consultants that we use, and has been used in historically throughout the years. So again, the board is looking at making changes to be more actuarially sound and more consistent with what other health plans on the commercial market do. And so this is just something that we're looking at as far as how to set up that dependent structure moving forward. And so will be discussed at the March board meeting.
Okay, great. Thank you. Thank you, Madam Chair.
Thank you. Next, I have a question from Assemblywoman Miller.
Thank you, Chair Peters. My question is, if we could go back a little bit to the health reimbursement arrangement, or the HRA, because I still have some questions. I know that Chair Peters was asking some questions about how the decision-making came about, but I really would like to get to the direct impact on participants, on our retirees. When we're looking at what, as Chair mentioned, it's a $30 reduction per individual at 15 years of service. But we also know that we have retirees, many that are on very fixed incomes, and $30 can be a huge impact on some people per month. So my first question would be, what exactly is the HRA used for? What does it cover? Does it cover, is it like a farm account like many employers offer, where I can use it for medication, I can use it for medical supplies up at the drugstore, I can use it to pay deductibles or copays or my Medicare? Can you first explain specifically? Because I think in this conversation, we're also using a lot of financial terms, and if we can bring it down to just, bring it down to terms that everyone understands, that we can speak in a language that everyone understands the impact or the purpose.
So for the record, Laura Rich, yes. So putting it into the human aspect and the human perspective. So the health reimbursement arrangement, what that is it allows the Medicare retirees to use those funds to be reimbursed for any kind of eligible medical expense. For specifically, and this only applies to the retirees on the exchange, they are able to receive reimbursement for premiums as well. Now, there are many Medicare plans that are at $0 premiums. And so there's many members, many retirees who do not incur an expense and do not have typically a reimbursable monthly expense. To put that into perspective, earlier through in FY21, the board met to do the first round of budget cuts, and one of the decisions that was made is to cap the HRA accounts at $8,000, because we had a very significant group of Medicare retirees who had either never used it or used it very, very sparingly. And this is a reimbursement. So it's different than a health savings account, where this does not, it's only used to be reimbursed for eligible expenses, and does not go with the member should they, it is returned to Peb should the member either pass away or move off the program.
So can you tell me what those eligible expenses are to be reimbursed for?
So any kind of premium is reimbursable. Any kind of drug expense, any out of pocket, copay. There are certain things that Medicare doesn't cover. For example, hearing aids. So that would be a significant expense that someone might use their HRA for. But as I said earlier, 94% of the reimbursements that are approved through the vendor that we use are for premiums. So this is to reimburse for either your Part B premium or your Medicare or your Medigap or Medicare Advantage plan. If there's any kind of, we have Medicare retirees who are on our dental that do receive dental from Peb. They're eligible to be reimbursed for that as well. So most of these retirees are receiving reimbursements for premiums.
Okay, and so with that, what is, because I know that, you know, I just experienced this with my own mother a few years ago, as she had to go through this whole process of finding, because the difference in years between retirement and Medicare until you get to, you know, there's a many difference in years. So I'm asking, so as you say that many people are using this for their Medicare and Medigap and the multiple overlapping programs they often have. So what is the average that they're paying? Because it looks like this will be reduced to $165 a month. So if there's $165 a month that the retiree can access, what is the average premium? What is the average retiree paying for that Medicare right now?
For the record, Laura Rich, I would have to get that from the vendor. This is not, so Peb does not, obviously, we do not administer those types of Medicare plans. We'd have to go to the vendor to find out what that average premium is. But so everyone has to pay the Part B premium, which is $149.50. That is the Part B premium. And then there's many folks who don't have a premium. They have a $0 premium. And then there are folks who do have other premiums, other plans, and doing for those premiums. So I'm happy to, I don't have that number on me, but I can definitely ask the vendor to pull that report and let us know what that average dollar amount is.
Please do, and please submit that to the committee, because I think it's important for us all to see the you know, between what is being reimbursed and what is what the retiree is actually paying, especially because this seems to be, according to one of your previous slides, about 8% of the budget. So 8%, I just want to, you know, the huge impact that this is going to have on so many of our Nevadans, our retirees. Again, $30 a month, we're talking about Medicare, we're talking about fixed incomes. I just want to make sure, or maybe you can answer that reduction when we go from the current $13 a month that's being contributed into the HRA to what is being suggested at $11 a month. What will the true impact be on participants?
So for the record, Laura Rich, there will be an impact. There will be an impact to those Medicare retirees because they don't have they will have a reduced amount for reimbursable expenses. So for those retirees who are using their entire $260 a month for whatever reason, maybe they have dental through Peb and they have a Medigap plan that has a premium, anything like that, then yes, they will be affected. Those members who do not receive or do not have additional expenses or out-of-pocket costs, they would not be affected at all. And so I think that getting that number, the average dollar premium through the vendor, I think will probably answer your question as to what is going to be, what is the impact, what is the reality of the impact to these members.
And Chair, with your indulgence, just one more final question. So with that, thank you, Chair. With that, could you find those numbers for us so as you're stating that, some have no premiums and some do have premiums. Is there a way that you could find those numbers for us too, so we could see what is the percentage of people that would actually be impacted? Because obviously if it comes back 95% of the people don't have a premium, that's a different scenario. But if we could also see not just what the average premiums that are being paid, but also the percentage of people that are actually paying premiums, I think that would be helpful as well.
For the record, Laura Rich, yes, I believe we can get you that information.
Okay, thank you. I appreciate it. Thank you, Chair.
Thank you. Let's see. Next question I've got is Assemblywoman Gorlow.
All right, thank you very much. And thank you for your presentation. I know this is hard for all of us with the way things are with COVID and just budget cuts. But I was wondering if you could explain the process and the time frame the PEP board will follow in setting rates, including participant premiums for plan years 2020 and 23.
So for the record, Laura Rich, yes, in March, the actuaries who today we use Aon Consulting will present a rate setting presentation to the board, and then at that point the board will then make a decision and approve those rates based on the subsidies that are being presented in our budget, and at that point then PEB staff moves forward after that March board meeting to include that in all of our open enrollment material and all of our benefit guides and anything going out to the members. So websites and website information and rate tables and things like that are updated to reflect the approved rates by the board in March.
Thank you very much.
I had a kind of a follow-up question related to the outreach to members or state employees who are eligible for these benefits and what that looks like. How do they get opportunities for one-on-one discussions related to the changes? Do they get explanation of benefits that include scenario descriptions? I know I've received that from some of my my providers. So could you just describe what that process will look like?
Sure. For the record, Laura Rich, yes, we do have very significant outreach, especially on a plan year like this. So for example, we are changing networks, which means that those members may have different providers, that they may be using a provider that is in network today, but will not be in network as of July 1st. And so this is one major outreach that we're going to be doing to ensure that members really do understand the changes that are coming. Also, we're introducing a new plan, so there's going to be member materials as well. Typically what we do, and some years are more intense and others depending on the changes to the program. So this year there's going to be major changes. We plan on putting together very, very robust presentations. What we do prior to coronavirus, we would go out throughout the state and put on open enrollment meetings so that members could attend and participate in these open enrollment meetings. We have moved to a webinar platform, which is essentially very similar to an in-person meeting, if not even better, because now members don't have to travel. They can log into their computer and participate. We have vendors that we coordinate with to ensure that they're available to answer questions by members, and so they give presentations and are available for any kind of explanation questions, things that are necessary through these. So we plan on putting together a program this time around, and I expect next year as well, given the potential vendor changes that we're going to be seeing. On top of that, we have everything is available on the website, the enrollment and eligibility system, that as you walk through that system and make any plan changes, it kind of, walks you through the different options that are available. So in a nutshell, yes, this is why sometimes making, if there are any last minute changes, are very difficult, because we don't want to present information and have that change. It confuses members, and healthcare is already confusing as it is, especially health insurance. And so we do our best to provide as much information and put together a very, very thorough outreach campaign prior to open enrollment every year. And we also do this for our retirees as well. We put on quarterly meetings for retirees, and to ensure that they understand that process and the Medicare process, which can also be very confusing as well. So we have a dedicated team of staff who are working on this as we speak, and are making sure that as much information is communicated as possible. Our newsletter went out yesterday to members, letting them know, hey, this is coming, this is what was in GovRec, and just kind of giving them an update as to, what is coming in July. So we do our best to communicate this as well as we possibly can.
Yeah, I hope so. This is it's a lot of people to all change or have the option to change plans in 30 days. So I like the idea of webinars. I think it's really, that's a really effective way of reaching people on their own times. So I look forward to hearing how that goes for you. I do, though, want to ask about your default. So my understanding currently is that as folks apply for insurance during that open enrollment period, if they don't make a selection themselves, they get defaulted to one of your programs. Is there any discussion around changing which program they're defaulted to, or will you guys maintain that high deductible plan as being the default?
So for the record, Laura Rich, so the default plan is typically, this happens when an employee is new. So when they're a new hire, if they don't select to, they can select to enroll in a plan, or they can do nothing. If they do nothing, then they do get they do get defaulted into that plan. They can also make the selection to decline insurance as well, but they have to take an action. If they don't take an action, then yes, they are defaulted into the lowest premium plan. And so that would be the employee only tier for the high deductible plan. There has not been a discussion to change that because it is the least expensive option. And so that it makes sense. You don't want to put someone into, default them into one of the higher cost monthly premiums, because once they are, obviously, after they are enrolled, they're stuck in it for a year, and unless they have any changes that may make them eligible, any life changes that may make them eligible to change their plan selections.
Thank you. All right, I have Senator Gocochea next.
Thank you, Madam Chair, and Ms. Rich. I just have a question and some real concerns about what we're looking at in trend and inflation. Clearly, we know over the last year, a lot of elective surgeries, dental care have been put off. And again, a year, we can only anticipate we're going to see a real increase in the use. We're reducing our reserves, reducing benefits, but is it also realistic to think that we're probably, as you set the rates in March, we will see a rate increase as well?
For the record, Laura Rich, part of the governor's recommended budget really focused on attempting to maintain stable rates. And so the actuaries, when this plan design was built, they do take that into account and look at what it might look like. And so I believe in one of the slides, we have estimated rates. Those were estimated because, again, we wait until March to actually set those rates. For this upcoming plan year 22, we expect those rates to be fairly stable. And the reason why is because in this last plan year, COVID has actually done the opposite. There's been claim suppression. So that means, people weren't going to the doctor, that they weren't getting surgeries. They weren't going and getting their dental needs taken care of. And so these are claims that the program never paid. And so coming into this plan year, we're looking at an abnormal and abnormally low utilization. And so that's what the actuaries are using because of COVID. And so this is obviously an anomaly, and it's not something that is expected moving forward. So this is the problem, is fiscal year 23, as you saw, the trend is at about 3.5%. That's what we're budgeting for. You said you had concerns about trend. I definitely have concerns about trend. It is something that, if COVID, if the delays in care that have happened as a result of COVID, if they turn out to if they result in higher healthcare needs, or the episodes of care that were not taken care of during this plan year are now worsening, and possibly in fiscal year plan year 23, if it doesn't pan out to be a 3.5% and it's something like 6%, that can definitely be very impactful to the program, because like I mentioned earlier, during the off year, there is no mechanism to adjust. The only way that we can adjust that employee, that subsidy level, or I'm sorry, the overall rate, is to either reduce the benefits or increase the premiums. And those are 100% borne on the participants during the off year, because we cannot change the employer subsidy levels during the off year. So it's a very, very significant concern for Peb moving forward, and is something that the actuaries are keeping a very, very close eye on. But as I said, COVID is just this unknown variable at this point, and we don't know what it's going to look like. And if we had a crystal ball, it could make planning purposes a lot easier, but we don't.
Yes, thank you, Ms. Rich, and thank you, Madam Chair. I realize it's a guessing game, but the bottom line is, when we look at 3.5% to 4% inflation, and we're already reducing benefits, I think this committee needs to be prepared, and we all need to be realistic. We probably will see, at some point, we have to see a rate increase, I believe, with the increased usage that's coming. So be prepared. Thank you.
Thank you, Senator. I think you highlight nicely one of the limitations of having a biannual legislature, and how much impact that can have on the people of the state. I have Senator Brooks up next.
Thank you, Chair. And this just, I just kind of want to expand upon Senator Gokachia's question. So should we, based on any information that we've received since the governor's recommended budget, should we modify the trend or inflation numbers that we're using for the 2021-23 biennium budget?
So this is Laura Rich for the record. That is actually a very good question, Senator Brooks. I'm actually having very initial conversations with our actuarial consultants who, again, no one has been through a pandemic like this, and so we don't really know what to expect. So our actuaries are doing a lot of modeling. They're looking at, the not just for Peb, but on a national landscape, what are the expectations? And I think that there's definitely been some talk about this on a national level. What is 23 going to look like? There's definitely a chance that 3.5% isn't going to pan out, and it could be a lot higher than that. So depending on the reality, if we do hit that 3.5%, and we're just talking medical, right? There's also the pharmacy side as well that can be impacted. But if we do hit that 3.5%, then that's great. Then everything works out perfectly. If let's say that trend is changed to 5%, because that's what there's a thought that maybe there's going to be more utilization and higher costs specific to Peb. And so let's say that we do change that, and then it doesn't pan out, and we're at 3.5%. Then we're going to accrue very significant excess reserves. And then there's the flip side. We don't change it, and we do experience that 5, 6, 7% trend. Where the plan will have to dip into our catastrophic reserves to cover those costs, and then, we'll probably a combination of all. We'll have to raise rates on members. We will have to reduce benefits. There will be action that will need to be taken. So whether this committee needs to adjust for inflation, it's hard to say at this point because of the COVID unknown, but it's definitely a risk moving forward for sure.
Thank you, Mr. Rich. I appreciate that answer. And Chair, I also had a question on audit, if you would allow.
Yes. Thank you.
So my question is about the audits that came out from LCB Audit Division in last year, and what, if any of the recommendations and findings of that audit, if they impacted this budget and impacted operating expenses of Peb.
So for the record, the audit focused a lot on contracts, which is why you see the slide on variables and the different contracts that we have out to bid. Peb, we are a staff of 34 people, and so we have gone out to bid on many solicitations already. This has been very, very taxing on the agency and on staff, but in particular for the budget, yes, it will affect the budget because it's another one of those unknowns. If you change vendors, what is the cost going to look like? We've had, for example, our third-party administrator. We've actually had the same third-party administrator for the last decade. And so, the fact that that Peb has not changed vendors and has not had a solicitation for a third-party administrator in the last decade, we don't know what are those proposals going to come in at when we move forward to, we put out an RFP for that vendor specifically. Same with our pharmacy benefit manager, right? So all of the potential changes that are coming out of these solicitations that we have, they can definitely impact the budget in some ways for the better, in some ways for the worse. For example, the PPO network, as you heard me say earlier, we went out to bid and we are due to save several $1 million out of that contract. But our enrollment and eligibility system, we ended up, the bids that came in were much, much higher than what we're paying today. And so there's, we're getting a much better service, but we're paying higher per member per month. So those definitely do impact our budget. Changing those vendors and going out to bid is, although it's probably the right, and it was the recommendation made by the auditors and the right action to take, and what a government, state government agency should be doing. It does introduce a variable of, planning that, what are the costs going to look like moving forward when we do go out to bid.
Thank you, Ms. Rich. And thank you, Chair Peters.
Thank you. And thank you for entertaining all of these questions and clarifying so much about what this program looks like. I know we have so many unknowns coming up in the near future and long term, and it's really, for lack of a better term, a juggling act right now. So if there aren't any other questions, does anybody else have a question? Oh, Vice Chair Howdy.
And just one last question, Chair. I promise. Okay. I wanted to see if you had explored at all what it would look like to participants if there was absolutely no plan design change, what that would mean as far as how much their premiums would go up, and if you guys during your board meetings had any public input on that, whether they would employees would prefer to keep the current plan design but pay more in premiums.
So for the record, Laura Rich, to answer the first part of your question, we knew going into, even before COVID, that retaining the current plan design with a flat budget, which I explained earlier is essentially a cut for Peb because our dollar does not go as far because of medical trend. So a flat budget to us was already going to impact the plan pretty significantly. What that looks like, it's hard to say right now. I know that was back in earlier in 2020, I believe it was in April and May when we were looking at that. I've seen probably 48 different versions of plan design since, so it's difficult to recall. However, yes, that was looked at. And it was something that we knew was going to have a significant impact on, either plan design or premiums and what that would look like. As to whether that has been a survey or anything of that sort has gone out to get member feedback, no, there has not been anything specifically that has gone out to to see if members are interested in retaining the current plan design, but willing to pay higher premiums for that. I believe in the governor's recommended budget, there was a concern that raising premiums, especially during a time when there's, you've got state employees who have furloughs right now. We didn't know moving forward if there were going to be furloughs in the governor's recommended budget. So there were some concerns that raising premiums would create additional barriers to members. But you're correct. There could be members out there, and I know that there have been specifically, one advocacy group did say that they preferred higher premiums over the over any plan design changes. However, that was in the governor's recommended budget. There was a focus on the access to care being relatively stable and not and so premiums would be one of those, and raise them too much and people might choose to decline them altogether and not have insurance. So it's definitely an option, but not one that we've actually gone out and surveyed members on specifically.
Thank you, Chair. And that was the last of my questions.
Thank you, Vice Chair, for that question as well. Well, are there any other questions from members of the committee? Thank you so much for the presentation. Again, this is a dense issue and really important to our state employees, and something that we'll continue to work with you on, I'm sure, with staff. So moving on to the next agenda item, which I believe is our last, and that is public comment. Do we have the public comment line open?
Sure, this is Michael from Broadcast. We do have the public comment line open, and we have about 8 callers. If you're ready for the first one, I'll queue them up.
Yeah, go ahead. Thank you.
Hello, caller with the last 3 digits 750. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
My name is Amy Payson, AMY-PASON, and I'm the Faculty Senate Chair at the University of Nevada, Reno. I have submitted written comment, but I wanted to emphasize that as the Faculty Senate, the elected representative body at the University of Nevada, Reno, we've been monitoring all of the proposed plan changes in relation to the governor's requested budget cuts. And we've definitely had concerns about the reduction of those benefits, as well as the reduction of the long-term disability benefit. And as a faculty, we are opposed to the elimination of the long-term disability benefit. And we are thankful for our northern and southern representatives on the PB board, Marcia Urban and Michelle Kelly, for speaking out against the elimination of the long-term disability benefit. As you heard in the presentation, that other state employees might have the option to be on PERS, or maybe there might be some employees that have paid into Social Security, but this is not the case for most of the faculty at NSHE. So I wanted just to remind the committee about who this elimination would impact. It would impact members like myself. I've been a faculty member at UNR for 11 years. Nevada is my home state. I came back here and I've been serving and dedicating my time to our state. But I wasn't given the option of PERS. I don't pay into Social Security. So with eliminating the long-term disability benefit, if something would be unfortunate to happen to me in the next year, what would be my options? According to the presentation, it means that I should go out on the individual market and see if I can afford to pay for that long-term disability benefits, or take my chances and wait in hopes that potentially LTD would be restored, or that potentially there would be a voluntary option come January 2022. In this pandemic time, it's very uncertain and has caused a lot of our faculty anxiety. So I know that we are facing tough challenges and we are making hard decisions, but we ask as faculty for this group to reconsider the proposed plan changes and hopefully be able to restore the long-term disability benefit. Thank you.
Thank you. Next caller, please.
Caller with the last 3 digits 853. Please slowly state and spell your name. You will have 2 minutes and may begin.
Doug Unger, D-O-U-G-U-N-G-E-R, UNLV Employee Benefits Advisory Committee and UNLV Chapter President, Nevada Faculty Alliance, for the record. Thank you, Assemblywoman Peters and distinguished members of the subcommittee, for your service and consideration. Dr. Ken Irvin of the NFA has sent you a detailed analysis of PEB that shows basically flat or diminishing state support for a decade, even as costs have kept rising for our health insurance and benefits. His analysis tells the story that Nevada has allowed health insurance and benefits to erode away like water does the foundations of an earthen dam. Please know that state employees are working through this economic crisis. We're putting in extra hours to cover short staffing and hiring freezes, many of us on the front lines of the battle against the pandemic. Faculty are teaching students through unprecedented challenges. Given this extraordinary work we're doing, the proposed Peb budget cuts are unconscionable. The elimination of the long-term disability insurance you've heard about today, you understand would leave 7,000 Nevada faculty with absolutely nothing should they become disabled. I received a phone call just this morning from a long hauler COVID-19 patient who is a faculty member who is desperate and saying, should I apply for disability now, or should I continue with my job and try to work through the after effects of this illness, because LTD will be eliminated. Please know that LTD insurance also covers medical professionals and staff with our medical schools who are risking their lives every day. Add to this that the proposed Peb plan designs with high out-of-pocket maximums shift unaffordable costs to the sickest, contrary to what fair and just insurance should provide. What this governor's plan actually does is shift costs to the sickest and most vulnerable, and that's what's most wrong with it. By cutting the $2 a month in NHRA contributions to retirees, it's a regressive tax of between $30, or most I know are going to pay $40 per month. An older retiree emailed me not 2 days ago asking how he's going to plan for his wife's upcoming funeral, God bless her, because life insurance too has been cut. Nothing has hit faculty morale more severely than this upcoming Peb budget cut. A professor with a $630 per month prescription cost wrote me, I'm thinking about taking a public high school job in Maryland. Another wrote, it's hopeless. The state doesn't care. So why do we care about the state? This erosion of trust affects diverse and minority faculty who are at a premium for hire elsewhere. We cannot retain them with diminishing salaries and shrinking benefits. Why should they stay? Unless we can do something about these Peb benefit cuts, we're just not going to be able to retain excellent R1 institutions. State advocates have been at the board meeting for 9 straight years, and we ask that you meet with us and listen to our possible solutions. Thank you.
Thank you. Next caller, please.
Caller with the last 3 digits, 111. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last 3 digits, 111. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. I'm going to move on to the next caller. Caller with the last 3 digits, 237. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Chair, I'll move on to the next call, and if at the end, I will go back to these ones that are having trouble connecting, just to make sure that they have a chance to speak.
Thank you. Thanks so much.
Caller with the last 3 digits, 338. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Chair Peters, Vice Chair Hudegay, Chair Brooks, and members of the committee. Can you hear me okay? Hello,
yes,
am I coming through? Thank you. This is Priscilla Maloney, representing the AFSCME retirees of Local 4041. My name is spelled Priscilla, Maloney. I thank the members of this committee for their attention to this complicated system this morning, and I will be following up with Vice Chair Hudagi, Chair Peters, and Assemblywoman Miller, because they specifically asked some questions that I believe the written public comment that I submitted does at least in part clarify. I think it's important to understand that retirees in particular, after the legislative session of 2011, have a somewhat more complicated history than the rest of the members on Peb. One thing that's important to understand is that I did link to Senate Bill 550. That's the appropriations bill from the 2019 session. And if you click on that link and look at that bill, it's only 2 pages, you will get a sense of what I'm trying to convey this morning through this non-visual audio process. There are retirees in Peb that will never be eligible for Medicare. It is arguably a small group, but because of that, in 1965, when Medicare was passed, Nevada did not pay into Medicare for its state employees. And so we have various tiers which are answered in this appropriations bill, and you will see people retiring before January 1. I'm looking at the second page of the bill, 1994. Those are the folks who are having the base amount of $195 that is subject to a reduction down to $165. Then a second group who retired after January 1, 1994, those are the folks who are getting the reduction.
We did receive
I'm
those.
sorry?
Can repeat. That was
Thank
the
you.
2 minutes. Thank you.
All right. Well, I'll wrap it up, but please, I will be following up with those committee members, and maybe they can share what I am trying to clarify here, because it is a complicated situation with the retirees. Thank you.
Yes, we really appreciate that. Thank you. Next caller, please.
Caller with the last 3 digits 237, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, and members of the committee for this hearing today. My name is Marlene Lockard, Lockard, and I am representing the public employees, retired public employees of Nevada. I think it's important to note, as Ms. Maloney stated, that in 2011, when Medicare retirees were offloaded from Peb, they left millions of dollars allocated to them in the Peb fund. In addition to that, Peb saves billions of dollars annually by not having Medicare retirees in the system. They do not pay any claims for Medicare retirees. I believe Ms. Rich also stated that the maximum amount a Medicare retiree could receive is $260 per month. On slide 11, I believe, the contribution for Medicare retirees from the state has been about 64%, and this budget will reduce it to 62%. But what you need to know is that the Medicare retirees don't receive that amount. While Peb continues to receive more dollars than it disperses to Medicare retirees, this budget proposes to cut that allocation even more. If the dollars are allocated for retirees, why aren't the retirees getting that allocation? And on the life insurance budget that is being proposed to being cut in half for retirees from $15,000 to $7,500, the top request from our seniors has always been to increase their life insurance to cover the burial costs. And the costs vary and are escalating. Seniors do not want to be a burden to their families and want to cover their final expenses.
Ms. Lockhart,
On the pardon me?
That was 2 minutes. If you could send your comments to the committee, we can review those if we don't already. I'm going to move on to the
Okay,
next.
but I would just like to add, this is a very important issue, and not having enough time to adequately respond to presentations is just not in the best interest of the public or the employees being impacted by this budget.
Understand. Thank you. All right, moving into next comment, please.
Caller with the last 3 digits, 837. Please slowly state and spell your name for the record. You will have 2 minutes and begin.
Good morning, Chair Peters, Chair Brooks, and committee members. This is Kent Irvin, E-R-V-I-N, representing the Nevada Faculty Alliance, the independent association of NSHE faculty statewide. Robust healthcare benefits are vital for recruiting and retaining state employees. In a repeat from the Great Recession, healthcare benefits for state employees are being cut to fill a budget gap. The Peb board made very difficult decisions in November on how to distribute deep 12% cuts. We appreciate that GovRec reduced the cuts overall, but it shifts a greater proportion of the cuts to the most vulnerable employees, those who become disabled in the future, and those with serious healthcare conditions who will pay higher out-of-pocket maximums, and retirees with fixed incomes. State employees are not covered by Social Security disability unless they've only been recently onto the state rolls, and nearly 7,000 NSHE employees do not have PERS disability retirement. So the long-term disability benefit is their only safety net. Eliminating it is cruel. Here's the scenario. A state employee gets cancer. She keeps working as long as she can, but puts the 5,000 out-of-pocket maximums for treatments on credit cards for 1, 2, or 3 years, and then can no longer work. With no long-term disability income, about the time she needs home hospice care is when the eviction notice comes. Insurance is meant to spread the cost of such risks over the whole population, but GovRec shifts it to that cancer patient or to the state Medicare and support services. Cutting benefits and increasing premiums is the most regressive way to hit state employees to fill the budget gap. The legislature should act to reverse at least the worst of the cuts in GovRec and restore the long-term disability insurance benefit and the retiree cuts. Time is pressing because Peb sets its rates in March, as you have heard. Finally, because of the continuing large fluctuation in excess reserves, Peb should be required to do an independent actuarial audit of its rate-setting methods and assumptions. There's more details in our written comment. Thank you very much.
Thank you. Caller, please.
Caller with the last 3 digits, 947. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hello, my name is Clarabelle Zesenia. That's spelled CLARIBELZECENA. I have been a state employee for 9 years and I represent AFSCME Local 4041. I urge this committee, which I understand is going through a very difficult time, to take into consideration restoring the benefits to long-term disability. You've heard, I'm not going to repeat, you've heard how we're in a dangerous position as public employees to keep our livelihood secure. And so I'm not going to rehash all of that, but I just want to really urge this legislative body to use their authority to balance the power to make sure that we do not continue to put the burden on public employees who, as we've heard, have gotten the cuts but never have gotten our benefits restored, even when we have been seeing a robust economy. So please take into consideration. The other thing I will note, though, is that Peb meets during the day when most public employees are working and therefore cannot take time to attend these meetings. The other thing, too, is that most of the time we're not notified of when they're meeting. They post it and their agendas, but we're all connected by a listserv and would wish that Peb would email us when they are going to hold their meetings so that we're also given more of an opportunity to participate in these meetings. So, but thank you everybody for your time and your consideration and everybody's hard work trying to get us through this difficult situation. Thank you.
And next caller, please.
Caller with the last 3 digits, 111. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last 3 digits, 111. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Chair, this is Michael from Broadcast. The caller line is open and working at this time, but there are no more callers.
I'm sorry, can I just interrupt? Did you say 7111?
Sorry, your last 3 digits are 111. Yes, slowly
Correct.
state and spell your name for the record, and you will have 2 minutes. You may begin.
Thank you. My name is Janelle Woodward, Janell Woodward. I'm a state employee and a member of AFSCME Local 4041 and the Peb and PERS Committee. While I understand the difficult time and the need to make budget adjustments and cuts, benefits are not the place to make those cuts. I oppose cuts to the benefits that we have earned. It is unconscionable to cut health benefits during the global pandemic when long-term effects of COVID are not yet determined. Just this morning, I read an article talking about early long-term effects of COVID. So this is clearly something that is being researched even at this time at only 1 year. From a personal standpoint, I'm an advanced breast cancer survivor who has already left with large amounts to pay for my medical treatment secondary to changes to our healthcare plans 2 years ago. Of note, my bills are in collection. With cuts to our pay and furloughs, I have no choice but to just accept that reality. In this year of a major pandemic, I have both continued to work my essential position and spent a week in the hospital, which significantly increased my debt load. The proposed cuts by adding deductibles and especially a 20% coinsurance to the EPO will be devastating not only to my financial situation, but also that of my fellow state employees. The proposed cuts add to the out-of-pocket that we are required to pay on top of the coinsurance and deductible. And for those of us with a medical history of cancer or other serious illness will be catastrophic for us. This will, and already has, put many medical options out of reach for employees. These aren't just simple cuts to deal with a budget. They affect state employees in very real ways. Please do not make our lives harder by putting us in a position of having to choose whether to obtain needed healthcare services or needed medications versus paying our rent, utilities, or even food. For many, that may be the difference of life and death. Eventually, we will end up unable to work or to afford to work for the state. Respectfully, I would ask that you please fund Peb appropriately so that our benefits may be restored. Thank you for your time.
Thank you. Are there any more callers for public comment?
This is Michael from Broadcast. There is one additional caller who just came in.
Great. Okay, let's hear them, please.
Caller with the last 3 digits, 499. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller with the last 3 digits, 499, please slowly state and spell your name for the record. You will have 2 minutes and may begin. Chair, that was the last caller. The line is open and working, and there are no more callers at this time.
Thank you. And I just want to thank everybody who called in for public comment. We're going to go ahead and close public comment, but I just want you to know that your input is invaluable in this discussion. And we really are working to balance the needs of our state right now. So thank you so much for participating. And if you did not have the opportunity to say as much as you would like, please submit your written comments to us, and we will have access to those on Nellis and can review those outside of this meeting. And if there is nothing else, then I think we are ready to close the meeting and adjourn. All right. Thank you all so much. Really appreciate the robust conversation today and look forward to next time.
Thank you, Madam Chair.